Perfect. So hello and welcome to the first RHAU Corporate Sponsor Highlight. Our team at the Rural Health Association of Utah is very excited to showcase organizations stepping up to support our association and in turn rural Utah. These are organizations who truly share our vision for empowering rural communities to thrive through equitable access to high quality care. And today we're pleased to highlight the Radiology Group LLC, and we're happy to welcome Dr. Anand Lalaji, MD, who is the CEO of the Radiology Group, which was established in 2006. Dr. A's vision was to offer an off-site subspecialty radiology services using state-of-the-art technology and proprietary one-of-the-kind supply chain interpretation model, which they call TRGASSIST. TRG is now serving 18 states and over 80 sites and growing. TRG and its portfolio companies cover full 24/7, 365 services for hospitals in every regard, or hospitals in regards to radiology interpretation, RCM services, denial technique reimbursement management, and radiology AI follow-up manager for additional follow-up on exams. Dr. A has been board certified as a radiologist since 1999 after earning his medical degree from SUNY. They call it SUNY, right? Downstate Medical Center. He completed his internship at Chestnut Hills Hospital in Pennsylvania and his radiology residency at Albert Einstein Medical Center in New York. In 2004, he completed a radiology musculoskeletal fellowship at Wake Forest University in sports. And Dr. A is an active member of the Society of Skeletal Radiology and specializes in sports medicine and diagnosis. Dr. A appeared on multiple media platforms such as Fox News, SiriusXM, CBS Radio, and he is committed to the rural community in guiding them to reduce radiology fees and helping the rural community be ready for the radiology services of the future. Dr. A, we're excited to have you, and to learn more about your organization, we'll turn the time over to you.
Okay, awesome. Thank you, Casey. The field of radiology for the hospital industry in the United States is of tremendous concern because of the massive shortage and the volume explosion with reimbursement cuts all at the same time happening all the time, every day of the year. And so the goal of this talk is to kind of tell the hospitals and the rural hospitals in Utah, all of the new things that we're doing for 2026 that is going to help them navigate and get their hospitals future ready in the rural setting. Because one of the biggest things, it's tough. The rural facilities are always, ignored. First the big hospitals get everything. They have the resources and everything like that. So our goal is, just like we're doing with our 80 plus sites, across the country, we're implementing all of these sort of, futuristic type of solutions for the hospitals themselves, just so that they can keep up and compete, without too much of financial burden. And that's basically our goal for all of our hospital sites. So our title, and this is the talk I gave at the AHA Rural Conference Leadership Summit in February. And I felt like this is very appropriate for, the rural health hospitals of Utah. The future ready radiology solution for today's hospitals. Let's go to the next slide. Okay, so I think everyone who's listening to this webinar can all sort of have a collective agreement on what's going on in the industry today. So there's a massive radiologist shortage, and probably also a massive radiology technologist shortage as well. It's leading to an astronomical increase in fees from teleradiology providers. Almost 30% of the industry is gone. And I can probably talk another 3 hours on why that happened, but I'm not going to do that. Just know that it's existing and it's getting worse every year. The problem is that, the fees are getting really, really high because of the supply demand curve. and the service is not improving. And so that is even more frustrating because the service is not improving, but you're paying a higher cost. And it's really tough for the rural facilities to be able to, take care of their patients, offer new services in their community, and try to do all of the things that are progressive and proactive. However, they're sort of putting good money, into bad and not getting the service that they need. And so, and it's evolved this way because of just what the industry is. The radiologists that are reading remotely somewhere else in the country, they have no skin in the game in process. They don't have a connection to the hospital. They don't really look out for the hospital, think about the hospital, outside of just reading exams. And so that's something that has really gotten away from the radiology specialty, and it's getting worse. As I said before, the hospital pays for more or for same or worse service. This is the old model. If you're going to continue to just want radiologists to read exams, that is not the way to look at the radiology industry in the modern era and what's coming, because that's the unfortunate thing. The radiologist a long time ago was part of the core clinical team, and that's the problem. They've now are some sort of distant bot that's reading exams and have no interest in the incentive or the betterment of the hospital itself. And that's what the radiology industry has become. And we have to reverse that trend. That's the goal with technology. And so that's why the hospital really doesn't have any strategic planning with the teleradiology group, and there's no development or personal professional relationships with radiologists, is because it's just, hey, read the exams, and I want to read the exams, and I don't want to talk to you guys, basically. So that's the biggest issue that has come about in addition to the shortage. Hospitals also do not have the structure to perform professional billing, manage denials effectively, and are experiencing high denial rates from imaging exams. And so, the advent of volume explosion also created a different type of explosion, which is denials on imaging studies from insurance companies. They just use AI now to deny imaging studies for the technical component and the professional component. And 95% of the fee structure that teleradiology groups give you is a fee per study, and then you have to do the billing. Well, here's the problem. The market for radiology services is double than what the insurance company reimburses. And so you are, no matter what you do and how you do it from a professional billing standpoint, you're still at best going to be collecting half of what you're paying out. And so you're essentially writing off the rest of the cost and not getting better service. And so, a lot of times your hospitals don't have the structure to really perform excellent professional billing. And there's so many new solutions out there from an AI billing standpoint that are going to be very effective. And I'll talk about that a little bit later. And then the biggest sort of white elephant in the room is that there are these large academic tertiary centers and large private health systems that are siphoning patients away. And it's not so much, it is much about losing patients to the rural community, but these patients have to drive an hour away, 2 hours away to get treatment because their physician may be an hour and a half away, where they could easily be in the rural community and get treated there and not have to travel these great distances, et cetera. So because of the private equity, capitalization of hospitals, their goal is to grow and to consolidate and to get bigger. Unfortunately, that doesn't necessarily translate to better care. And so you're losing patients from a follow-up exam, and all of those concepts are going away. And so that is sort of, I probably didn't cover all of it, but 95% of what all of the rural hospitals are facing in radiology is basically this slide. And so let's go to the next slide. Okay, so one of our biggest principles is that we just don't throw band-aids on things. Okay, our biggest thing is we have to have an inherent fundamental philosophy that percolates throughout our whole organization that will help the plight of the rural hospitals in terms of becoming ready for radiology in the future. One is that we have a skin in the game mentality. Okay, so we want to develop processes with the rural hospitals to basically help them mitigate cost. We know that they're going to have to pay a higher cost to us or anybody else in the industry because that's just the way how much radiologist costs. Our radiologist cost has gone up about 250% compared to about 6 years ago. So no matter who you go to, and beware of the ones that are just saying we'll do it for extremely cheap because you're not going to be able to probably get the service that you need. But you pay for what you get. And so the biggest thing here is that if you're going to pay us a higher fee, we want to try to give you back that fee in other solutions that we will provide to you within that fee schedule so you don't have to pay anything extra for it. So the skin in the game with our We Care model, the hospital pays a fee schedule like any teleradiology group, okay? We will take over the professional billing because we have an AI billing component, essentially playing the game that the insurance company plays. We basically, our algorithm is better than their algorithm. And then algorithms are fighting with algorithms, essentially. And that's basically how you collect, how you collect that. And so, so one, that's what we do. So we take it off the hospital's plate, we do it better, and then we give all of the receipts back to the hospital so that they can collect as much against what they're paying us from the service standpoint. We also have a reread solution. So all of your imaging denials for your technical component that you get that states stuff like not medically necessary or things around that line, we reread the exam to make sure we've picked up on all of the chronic findings. Then we give you back that report and you submit the claim again. And then the claims that have been written off originally, you'll get paid for. And then we have a success fee. We share in that success fee in a 50-50 manner. So that way, you're not paying any upfront fee, but you're also collecting things that you would once be writing off. And so that's the first. The billing is one. Two, the billing is one. Two is the reread exam that is offsetting the fee. And the third thing is, I'll talk about that a little bit later. That's the AI. That's one of our companies. We believe in relationships. The radiologist has gone away from having a relationship with the hospital. We personally visit on site after implementation and every 6 months to discuss issues, but mainly to push strategic growth of the radiology department. So what we do is we set 6-month goals every single time we come, whether it's volume related, type of exam, new exams, new technology, new strategies, whatever it may be. We work with the hospital to figure out what they are missing. If there's equipment that's sitting around the department that's not being utilized, let's look at that, right? And so basically that's how the professional and personal relationship, we want to know who we're working with. You guys are not all of our partner hospitals know who we are, and that's the big thing in teleradiology. Most hospitals have no idea who these companies who they're contracting with. So that's one big thing that we do that no one's ever, in a teleradiology standpoint, no one does that. But we believe, and that's how we've been growing very, very slowly for rural facilities. We've been around for 25 years and we service 80 plus hospital sites. So if you can just imagine the numbers, 3 to 4 hospitals a year, basically, that's it. And so, we really, really care about the success of the hospital that we cover. We live in a digital world. And so text messaging, emailing, and calling are really, really old technologies, especially in the healthcare system. So we have a platform It's on mobile and it's on desktop. It's called DocSync, where we give user access to every single person in the hospital. And so, because everybody goes through the radiology department in the hospital, there's not a single person that doesn't interact with the radiology department in the hospital. So we give it to everybody, and they can ask questions on that platform, and our rapid response team answers it immediately and then tries to get the answers all through the app. HIPAA compliant. You could take pictures, you could take screenshots, you can do video calls, etc. So we communicate with all of our referring physicians and radiology department and nurses and all of those people via the app. And it's one of our real great success stories because we feel like we know the hospital. We communicate with them hundreds of times during the day so easily, whereas if you just had phone calling and text and emailing, you probably have 10% of that efficiency. So that's one of our biggest pride things that we have done, and it's really worked out. Our mammography is a big thing in the rural community. A lot of teleradiology groups say they don't do diagnostic mammography, they don't do screening mammography. You have to find somebody else, etc. Well, it's its own animal. We have our own virtual breast imaging platform, and we specifically convert each hospital to a breast center of excellence. And so from screening exam to diagnostic mammo to breast ultrasound, and we try to keep adding new technology. So breast MRI, biopsies, and that sort of thing. We take great pride in making sure that we can build, develop, start, or whatever it is, a mammography women's imaging program at the hospital because it makes a huge difference to the community. One of our biggest things is that the old hub and spoke model does not work anymore. So typically, historically, you guys have probably been seeing this, but you essentially have a hospital that is, a radiology group that covers a large hospital, and then they pick up like a bunch of smaller rural hospitals. And so they always give the bigger hospital priority over the smaller rural ones, right? And so that is a real big issue now because of the shortage. So every single one of our 80 plus hospitals, they're all rural, all of them. So everyone has the same priority on our system. There's not like a hospital that we give higher priority to. The priorities with the priority on the system. So it's a stroke, ER, whatever has the priority. It doesn't matter what facility is, it will have that priority. So our turnaround times are consistent. So we're not like if the big hospital is sending us 1 million exams and we can't get past that to read for all of our rural facilities, that doesn't happen in our system. It's all the same priority. Okay. So one of the biggest things that we get from all of our hospitals today is that you take all this time to follow up patients, and you bring patients in and you treat them at the rural facility, and then they disappear. They go to the larger facility and they lose patients to that because of their marketing tools, because of their technology, because of all these other things. That is a big issue. And things that rural hospitals that don't understand, 60 to 65% of all hospitals under 100 beds lose anywhere from 60 to 70% of their follow-ups. So you have a patient that needs a follow-up CAT scan. There's a 60 to 70% chance they're not coming back to the hospital for that CAT scan. And that's a problem. That's a big problem with larger facilities siphoning stuff away. And so, again, this is sort of the beginning part of explaining what the Radiology Group's sort of mission statement is and how we do our solution. Let's go to the next slide. Okay, so let's talk about our radiology AI follow-up manager. Okay, so it's a software and technology called Inflow Health, and what that does is basically as soon as the radiology report is read, we have a report. We have a simultaneous process of this software / robot that reads the report. It will pick up on indirect and direct follow-ups, basically. And so I'll give you an example, an X-ray of the cervical spine. The findings talk about all of this osteoarthritic change and, of the neck, but the impression says no acute fracture because that patient has come through the emergency room, so there's no acute finding. But they do have a lot of findings in the neck that is causing their pain, but it's just not acute from an emergency standpoint. Well, that patient should have an MRI of the cervical spine. You'll be shocked to know that most of the time does not get ordered because there's no direct recommendation at the bottom of the report, okay? Because the radiologist is just reading it for acuteness sake, not for chronic or whatever it may be. So what our technology does, Inflow Health, it basically reads that report and it will pick out, it says, oh, wow, look at all this degenerative disease. It says most appropriate follow-up is an MRI of the cervical spine. And it will prompt the referring physician in the electronic medical record to order it, yes or no. 9 times out of 10, they say yes, because it's another technology that's protecting them, protecting the patient and all of that. And then it automatically gets ordered. And then what Inflow Health does is puts a geofence around the patient to make sure they do come back. With their call center, all of that. And the beauty is all of this technology is built into the fee schedule. So the hospital is not paying anything more and now gets to reap the benefits of 3 things. One is patient safety. So patients come back, they get their follow-up exam, so nothing gets lost. 2, mitigation of risk for the hospital, right? So making sure that the follow-up is there. And 3 is all of these follow-up exams that have been, all of these follow-up exams that are coming in now, that are staying at the hospital, that are not getting lost, are basically additional revenue for the hospital. And so that revenue plus our reread revenue plus our AI billing all offsets the fee schedule that is being paid. And so that is the mission. The mission is, if you're paying us $100, we're billing $50, collecting it for you. We're getting $25 for the reread, and we're getting $25 for the RAD AI follow-up manager. So then that $100 you're getting back, and then you get net 0 fees. And it's working, and we're really excited to basically, implement this across every facility, because, I think any facility would want to have all their radiology fees back. So I think that would be a good idea. And so let's go to the next slide. Okay, I'm not planning on everyone memorizing this. It's so small. But this is essentially what our spreadsheets look like for our customers. You have the fees on the left, you have the billing collections in the middle, and then you have the net subsidy after the billing. And then as we collect more, there's a read fee discount. So you're actually getting a discount off the fee schedule. And our billing fee goes up a little bit, so to incentivize us to collect more and more and more. But at the end of the day, this is how we collect better professional billing receipts than the hospital could in that regard. So this is that billing spreadsheet in year 1, year 2, and year 3. This is an actual hospital, but it's one of our sample hospitals essentially by month. Okay, let's go to the next slide. Okay, to summarize this, so if you look on the left side, you have model above year 1. Okay, so you have whatever is being paid. The net credits is the billing collections essentially, and then so the net subsidy is the fee that's paid minus the billing collection. So in this case, you start out with a $364,900 net subsidy, because that's the difference between what you're collecting and what you're paying, essentially. Then you take the revenue on the right, follow-up AI, the Inflow Health product is adding $58,320 back, and then the reread division is adding $14,580 in year 1, and so your total net subsidy is $292,000 versus the $364 or even higher that you would pay without any of this stuff. Year 2, okay, the net credits go up because we've collected better, $703,000. So the net subsidy is $143,000. Follow-up AI has increased to 84,000, and then the re-read division has increased to 21,000. So your total net subsidy now is 38,000. So you've only paid for $38,000 for the whole year for your radiology service from a net standpoint. And then, year 3 is pretty much the same as year 2. However, there are certain situations where we actually make it a profit center, where we're actually collecting, we're adding so much more follow-up exams that this becomes a profit center. And that is not heard of before, is that, whoa, we're paying you $700,000 a year and we're getting back $721,000 a year. So this is what you can do now with AI, with our model, is to get you to net zero fees. Okay. And I think, let's go to the next slide. Yep, I think that's it. We got through it. And I know this is a lot to consider, but there is in order to navigate for radiology, the future of radiology in rural hospitals, you have to go through this process of becoming very, very integrated with several technologies that make a true difference to the financial impact, because we are never going to, it's going to be 25 years before radiologists become, a surplus again. And it may never happen, because as AI gets better and better, then the numbers of radiologists will continue to go down. So this is so important that you use technology and new things that are coming out for risk mitigation, for patient safety, and for adding diverse resources to the community via netting out the cost of the service by collection of all of this new revenue that once was written off. And the goal is we collect, you get to net zero, you invest that newfound revenue back into the hospital, back into the radiology department, you offer more services, you offer more exams, different types of exams, you attract different doctors, and then we continue to keep pushing this process, and then you keep reinvesting it, and it creates its own replicable cycle. And then that's how you can succeed in this world that we're going into. Thank you for your time. I hope you guys understood all of this. Casey, if there's any questions, I'd be happy to answer them.
Yeah, I just have a couple comments. Thinking back on our rural facilities in Utah, I think billing and revenue cycle management are always a challenge, and we know that the insurance companies are using AI against the hospitals and the settings of care in order to deny claims, and being able to leverage AI back. And I love that analogy that you gave. It's just two AIs battling each other to see who wins.
Yeah, basically. Yeah.
But from my viewpoint, if a hospital can lighten their load on revenue cycle management while also increasing their reimbursements, decreasing what they're paying for radiology, and most importantly, I really appreciate that you actually go out and talk to the hospitals and meet with them and get to know each one individually, because that's so important to us in rural Utah, that somebody actually comes out and makes that effort, because nobody wants to be relying on a radiologist in a life-threatening situation that they don't even know what they look like, never seen them in person.
Right.
I think that elevates the level of confidence they have to work with your group. They know who you are. They've seen you in person. You come to their facility. That means a lot to rural. And I hope that our hospital administrators and groups that are viewing this will recognize the value added there, and that this is truly a situation where you're trying to be an active partner and meet them where they're at and invest your own resources into helping them succeed, and not just coming along with another solution that looks like what everybody else offers.
And the interesting thing that you bring up, Casey, is that most radiology companies now they're just trying to add as many contracts as they possibly can to grow and then to sell, basically, right? Yeah. And we are a legacy company. Like, we've been approached by private equity for a decade, and we've turned everyone down because my wife, Dr. T, she is the national LIP. She is a double-boarded neuroradiologist and breast imager. She runs the whole breast program. Our kids are interested in the business. We have family. This is a family business. us. Okay. And we have grown up. My wife has grown up in a rural community. We know that we know you people because we are in a, like, because that's who we operate with. It's really, it's communication, simple, develop relationships, offer simple solutions, and then have an incentive to work it out to basically be successful, right? And so we don't consolidate in hordes, right? We basically want people that want to understand our model, that are bought in, that want to work with us, right? Because that's when the thing works. If we're having to continue to convince someone, down the road that something like this works, then they probably don't have the same sort of goals that we do. But the ones that truly embrace the relationship and then embrace the technology and we work together with it, it really, really makes them successful. And I think the hardest thing for them to get their hands around is that for 25 years, radiology has been talked about one way, right? And now it's not working. So it's hard to like turn that aircraft carrier around, right?
Right.
But it is happening in our system, and it's just a constant perseverance. But yeah, I really appreciate it. We really love coming and visiting and talking to everyone and developing that relationship. It gives us great joy.
Well, and Dr. A, we really appreciate the support for RHAU and look forward to working with you to help increase these services and improve radiology in rural Utah. For anybody watching this, Dr. A, your team will be out at the RHAU conference in November as well, correct?
Yep.
Yep.
We will.
Yeah, they'll have a table there. You can come visit with them. And this recording will be posted on our website. If you go to our homepage and you scroll down to the corporate sponsors, you can actually click on the Radiology Group's logo there, and it'll take you right to their homepage. So you can connect with them there as well. And we thank everybody who's viewing this recording and appreciate your time and attention to learning more about the Radiology Group and the great work that Dr. A and his team are doing. And we hope you all have a wonderful day.
Thank you.